We can stop in between, doesn't matter. The questions keep coming. So the time we start at 4:50, 4:20 now. So you want me to finish by 5 o'clock?
Yes. 5 o'clock.
Okay, doesn't matter. I think I'll finish before that because questions are more important. Okay, so good afternoon. I'm Professor Dr. Vivek Gupta. Are you able to hear me very well?
So I will welcome you, sir, and then Charity will introduce you, and afterwards you can start the presentation, sir.
Okay.
Good evening, everyone. Welcome to the second webinar of this AFF webinar series. On behalf of our Honorable Founder President, Dr. Ashok Chauhan, our Honorable Chancellor, sir, Dr. Atul Chauhan, and our Vice Chancellor, Madam, Dr. Balvita Shukla, and on behalf of my all colleagues from Food and Agriculture team, I'd like to welcome you, sir, to Amity University for this second webinar series. And so I welcome you, sir, to this webinar series, and I hope the people will be benefited by your lecture on this COVID-19 and its impact on the heart. So I hand over the mic to Shakti so that he can read your biography. Thank you.
Thank you, ma'am. A very warm welcome and good evening to Dr. Nutan Kaushik, Director General, Amity Food and Agriculture Foundation, dignitaries, esteemed colleagues, and dear students. With extreme privilege, let me avail the opportunity to introduce today's guest speaker, Dr. Vivek Gupta. Professor Dr. Gupta is presently associated with as Senior Interventional Cardiologist in Indraprastha Apollo Hospital, New Delhi, since 1919. Carrying out the clinical and invasive work of coronary angiography, balloon angioplasty, stenting, and valvoplasty and pacemaker. With rich experience of about more than 10,000 angiography and 5,000 angioplasty and stent implantation in India. Sir is founder, co-chairman for International Cardiology Teaching Courses, into European course of revascularization for young interventional cardiologists. Sir is chairman for Indo-European Conclaves. Today, Dr. Gupta will give us view on COVID-19 pandemic and its impact on healthcare in the heart. Over to you, sir. Very warm welcome to you.
Hello, can you hear me?
Yes, sir.
Yes, we can. Yes, we can.
Okay, good afternoon, and it's a very nice day, 23rd of April, and thank you, the Amity University, thank you, Dr. Chauhan, who is our personal friends, and this family, Asim Chauhan, for giving serious issue for last 4 months, started in Wuhan, China. Nobody knew Wuhan before that. I mean, the public did not know except for the businessmen. And now we are facing such a huge trouble with WHO announcing it as a pandemic. There have been several pandemics, but this is the most severe after the Spanish flu, which came in the early 90s, 1902. So it has already killed. So let me go on to the slides. And with thanking to Amity University, we have a special relationship. My sons have studied there, and now they are doctors. So we have a special relationship with Amity and the Amity founders, Dr. Ashok Chauhan. So I think I'm going to share the slides now, and I think I can share the slides now. So let me go to the sharing. Okay, so can you see the slides? Hello?
Yes, we can.
Okay, good. Okay, so I'm going to start my lectures. The lecture will be COVID-19. I used to give a lot of cardiology lectures, but these days I'm also talking about this virus disease. So today, as of now, this is SARS-CoV-2. There have been SARS-1 also, but this is SARS-2. The SARS-1 came as MERS, and MERS and other things. Let me go to the total deaths. Before I start, I would like to tell you what's going on in the world. As of today, WHO website, I found that 26 lakhs people, that means 2.6 million, we are using lakhs is better, are affected, and that there have been more than 18 lakhs death all over the world. This is a huge problem for the whole world, and we are trying to still find the solutions are still not there. We are trying to use various medicines. I will let you know. For today, it is 21,000 of infected patients in India and 681 of deaths. So overall, the situation is very not so good, but of course, we are trying our best. Our Prime Minister Narendra Modi ji, one of the most respected Prime Minister ever in India, is doing the best with the lockdown and other things, and our Health Minister Dr. Harshvardhan is doing the best with all the Chief Minister of various states, trying to support the whole cause. So coming back to the disease, I would like to show you this slide for the interest of the audience. Mostly people are non-medical, as I know, but still for the interest of audience, I would like to share what it is. So diagnosis of COVID-19 is done by the help of SARS-CoV-2 entry and replication. It goes into the cells. Then there is the antigen presentation, cellular immunity and humoral immunity. This is how all the virus are doing the activity once they infect the person. I will tell you a little about the genomic of the virus, because this is interesting for the discovery of vaccine and plasma therapy. So I would like to give you some basis, although it may not be so interesting for the non-medical people, but I think everybody is reading biology, so they know everything. Coronavirus entry and replication. Coronavirus S protein has been reported as significant determinant of virus entry into the host cells. The enveloped spike glycoprotein binds to its cellular receptor ACE2 and SARS-CoV and SARS-CoV-2. The entry of SARS-CoV into the cells was initially identified to be accomplished by direct membrane fusion between the virus and the plasma membrane. Bulzo et al. 2009, when there was the first epidemic or pandemic of SARS in 2008 and 9, found that the critical proteolytic cleavage event occurred SARS-CoV protein at position S20 mediated the membrane fusion and viral infectivity. So after the virus enters the cell, the viral RNA genome is released into the cytoplasm and is translated into two polyproteins and structural proteins, after which the viral genome begins to replicate. The newly formed enveloped glycoprotein are inserted into the membrane of the endoplasmic reticulum of Golgi, and the nucleoplasmid is formed by the combination of genomic RNA and nucleocapsid protein. Then viral particles germinate into endoplasmic reticulum, Golgi intermediate compartment. At last, the vesicles containing the virus particles then fuse with the plasma membrane to release the virus. Antigen presentation in coronavirus infection. While the virus enters the cell, its antigen will be presented to the antigen presentation body, which is central part of the body of antiviral immunity. Antigenic peptides are presented by MSC or human leukocyte antigen in humans and then recognized by virus-specific cytotoxic T lymphocytes. Currently, we don't have any report about antigen presentation of SARS-CoV-2, and we can only get some information from previous researches on SARS-CoV-1 and MERS-COVID. Coronavirus, not COVID, coronavirus. So the antigen presentation of SARS coronavirus mainly depend on MSC1 molecule, but MSC2 also contribute to its presentation. The humoral and cellular immunity. Antigen presentation subsequently stimulates the body's humoral and cellular immunity, which are mediated by virus B and T cells. This is important because the second line of body testing, which is happening with the ICMR getting the kits from China, where they are testing the antibodies, and that shows that patient has been exposed or the person has been exposed. This is how the antibodies are formed. Similar to the common acute viral infection, the antibody profile against SARS-CoV coronavirus has a typical pattern of IgM and IgG production. These are two types of antibodies. The SARS-specific IgM antibodies disappear at the end of week 12. IgM disappear at the end of week 12, while the IgG antibody can last for a longer time, which indicates IgG antibody may mainly play a protective role, and SARS-specific IgG antibodies primarily are S-specific. And comparing to humoral responses, there are many more researches on cellular antibody. This is just to give you the basic how the antigen and antibodies are useful for the treatment of the COVID or coronavirus 2. The latest report shows the number of CD4 and CD8 cells in the peripheral blood of SARS-CoV-2 infected patients significantly reduced, whereas status is excessive activation at a high proportion of HLA, DR, and CD38 double positive proteins. So the acute phase response in patients with SARS-CoV is associated with severe disease of CD4 and CD8, and even if there is no antigen, CD4 and CD8 memory T cells can persist for years in part of SARS coronavirus. The specific CD8 and T cells also show a similar effect on MERS virus clearance in mice. So cytokine storm, this is important. One report in Lancet shows ARDS, acute respiratory distress syndrome. This is the final stage in the very sick patient, is the main cause of death. I will tell you here, which is very important, not to just to reduce the panic. Of all the coronavirus patients or COVID-2, COVID-19, only 5 to 10% become serious, and that is also having the age relationship. That means 80% behaves like a common flu, which is only cough and mild fever, and they are quarantined. We are facing problem of COVID-2 more than any other flu is because of his high infectivity. This patient who becomes COVID-19 infected has a high infectivity, and therefore they are prone to infect other people. According to ICMR, one person can infect about 400 people in general. This is an estimate. So the cytokine storm is the last event which happens, and this is a serious condition where the patient has septicemia, patient has hypotension, patient is on ventilator, and patient finally succumbs to death if they are unlucky. Out of the total proportion of 100 patients, 80 will recover, 20 will become mildly serious. Out of those 20, 10 will become very serious, and about 5 will die. This is general. But patients who are more than 80 years of age, the mortality is about 20%, 15 to 20%. That is what happened in Italy, and what is happening in USA, Spain, and other part of the Europe. So this is cytokine storm. Diagnosis of COVID-19. Clinical diagnosis are mainly based on epidemiological history, clinical manifestation, and then of course you have to diagnose with the nucleic acid detection, CT chest, and other things. Clinical symptoms and signs of patient infected with SARS-CoV-2 are highly atypical, but including respiratory symptom, cough, fever, and dyspnea. We always tell patient who has a dry cough, it is not a productive cough, there is no sputum. It's a mainly dry cough with a moderate to high grade fever and breathing difficulty. And those patients who further deteriorate, they have viral pneumonia. So this is how the patient presents clinically. Coming on to the nucleic, what are the tests we can do to confirm that the patient is actually having the disease? And this is PCR test. You are reading in the newspaper PCR test. What it is? It is real-time quantitative polymerase chain reaction, and with this we can actually confirm that this patient is infected. The best diagnosis is done by SARS-CoV-2 in virus, is the virus in the blood culture, but which is not possible to do it, and we are not doing it. What we are doing is the application of high throughout sequencing technology in the clinical diagnosis limited because of equipment dependent in this. So the most common is that we take the respiratory secretions. RT-PCR is the most common, effective, and straightforward method for detecting pathogenic virus in respiratory secretion. They're taken from the throat. We are not doing the blood or the whole world because that becomes a culture, takes about 3 to 4, 5 days. Even this test, RT-PCR, this test also takes about 24 to 48 hours. This is the limitation. But it's a highly specific test for the confirmation of COVID. And this is being utilized all over the world since December 2019. So RT-PCR is a specific test for diagnosis of COVID-19. It is, I told you again, I want to repeat, it is not a blood test. We can do blood culture, but that takes longer time. It is done from the respiratory secretion because this virus goes into the respiratory tract, and therefore we take a swab from the throat and then we send it to the laboratory, and the test is available in 24 to 48 hours. However, its false negative rate cannot be ignored. Even this test has a false negative rate. That means the patient can be actually suffering and the test can be negative. That means test is normal and the patient is having COVID. because of the severe consequences of misdiagnosis. Therefore, CT scan can be considered necessary auxiliary diagnostic method because it is more sensitive. For individual with a high clinical suspicion of SARS-CoV infection with a negative RT-PCR test, a combination of repeated RT-PCR and chest CT may be helpful. This is a very important statement. I want to again repeat it. There are patients who are having high clinical suspicion. That means they have high grade fever, they have traveled outside, they have come in contact with a person who has been suffering from COVID and still the RT-PCR is normal or negative. Then what to do? Then you have to do a CT scan. Especially the high resolution CT, HRCT for the chest is essential for early diagnosis and evaluation of severity of patients of SARS-CoV-2. So this is important. What are the CT scan figures? The typical CT images shows bilateral pulmonary parenchymal ground glass and consolidated pulmonary opacity, sometimes with a rounded morphology. Sometimes with rounded morphology and peripheral lung distribution. Transfer CT image from 40-year-old man. This is how it looks like. This is more for medical people to understand. A radiologist will do the diagnosis. We as a cardiologist and even the people will not be able to do. Just to tell you, the CT scan is important diagnostic modality. CT of the chest, not the brain. CT chest is very important diagnostic modality. How medicines work. Let me give you a small example how the medicines are working actually. So let me go into this. I don't know, it's a very smallly written. SARS-CoV-2 virus, they enter the cells. And here this is inhibits the TM pathway, prevents viral cell entry and membrane fusion, endocytosis. At this point of time, chloroquine, hydroxychloroquine is useful. Then this goes into further make the polypeptides and then non-structural proteins, RNA-dependent RNA polymerase is very specific. But this is where the antiviral medicines, lopinavir and duranavir, they work. At this point of time, these are antiviral medicine, they work here. Ribanavir and remdesivir, which is very utilized these days, these are working at the RNA-dependent RNA polymerase. This is just to give you an example. Although there is no specific medicine as of today which can really cure or treat it to that extent that the patient does not die, but there are methods which can be helpful, and this is how to show you the diagram of this. Very important, talked about hydroxychloroquine. Today morning I was reading and there is a literature coming from USA that this is not useful. But let me tell you what is hydroxychloroquine, how does it work. Hydroxychloroquine is a compound which is used for the autoimmune diseases. It is known as HCQS. It is a brother of chloroquine which is used for malaria. Is a little different compound, but this is not used for malaria. This is used for basically autoimmune disease like rheumatoid arthritis, SLE, and lot of patients who have a small joint disease, they take it for the life. It has a very less toxicity. But when the Indian Council of Medical Research about 2 weeks back, they said and they released a guideline that this can be used for the healthcare worker as a prophylaxis. That means those people who are working in the healthcare, that means in the hospitals, the hospital doctors, nurses, ward boys, housekeeping boys, delivery boys, the medical store staff. So these people should take hydroxychloroquine in a very fixed dosage, 400 milligram twice a day for 1 day, and then 400 milligram once a week for 7 weeks. Very clear-cut guidelines from Indian Council of Medical Research. Let me tell you that my father worked for Indian Council of Medical Research for years and he now retired. He did a lot of researches. People generally did not know about that. They know Apollo, they know Amity, they know AIMS, but they don't know ICMR, which is a leading research body. So thanks to this COVID, whatever say, this is not thanking him, but because of this, everybody now knows ICMR. So ICMR gave the guideline that this drug should be used prophylactically only for the healthcare workers. So a lot of questions came because there are a lot of friends who keep asking, can I take it? So I said, if you are moving out of the home, for example, police, their field staff, they said if they are actually exposed, then you can take it because it does not have major side effect. Professor Didier Rolt, he is a French doctor working in Marseille. Marseille is a small city in France, but it has a very high level of work as far as virus is concerned. He initially was himself skeptical that this is not going to, he released a video and that video showed that this is not working very well. And in fact, it can be dangerous. What was the danger? The danger was that this hydroxychloroquine in a specific subset of patients can cause, especially those who have an increased QT interval. QT interval is a very small ECG type of diagnosis, and these patients are actually prone for arrhythmias. Arrhythmia means ventricular tachycardia, ventricular fibrillation and sudden death. But they are very specific few percent of patients, and where we have to be careful. So he said, don't give this medicine. Then he did a study of 1,000 patients. 1,000 patients were studied and posted on April 9. I'm going to read this. The new study of which the abstract were released today, this was April 9, very recently, 10 days back, was performed at IHU Mediterranean Infection, Marseille, France. A cohort of 106 COVID-19 patients treated for at least 3 days with hydroxychloroquine and azithromycin, which is an antibiotic combination, and a follow-up of at least 9 days was investigated. He released the results of the new hydrochloroquine. No cardiac toxicity was observed in these patients. 1,000 patients. It's a large number. A good clinical outcome, a biological cure was obtained in 973 patients within 10 days. 91% patients was having a good clinical outcome. A poor outcome was observed in only 4%. 10 were transferred to ICU, 5 patients died, and 31 required 10 to the hospitalization or more. So this prompted everybody to that this can be used not only as a prophylaxis, but also the treatment of COVID-19 to reduce the patient's viral load so that the patient does not become serious. You see, it's a flu. It's a common flu. Common flu, you know everybody, we have been suffering from flu for last so many years. As a childhood, we had flu, khansi, जुकाम, बुखार. उसको हम लोग treat भी नहीं करते थे because the body has its own immunity. The problem is when this is a new virus, it is more dangerous for two reasons. One is because it can actually infect so many people at the same time. Secondly, few percentage of patients will go to that seriousness that the patient will actually die. And therefore, this is dangerous because the immunity is still not there. This is only the herd immunity is not there. That's why we have to know the treatment. So the French perspective, the SCQ azithromycin combination, when it started immediately after diagnosis, is safe and efficient treatment of COVID-19 with a mortality rate of 0.5% in elderly patients. 0.5 only. I told you in general it is 5 to 10% or 20%. It avoids worsening of clear virus persistence and continuity in most cases. Before I go on to the other part, let me tell you what has happened. Lot of people must have read today morning newspaper. And the today morning newspaper said there is a study from USA of only about 300 patients. And they found actually the worsening. So it is difficult to say this is a French study and that is American study and less number of patients. I would say that in general, if the patient is not having cardiac disease, this is a very safe compound. Maybe those patients who were treated in America, which a study was published on today's newspaper, it is viral yesterday evening, maybe those patients were having more of cardiac patients. But for the cardiac patient where the QT interval is prolonged, hydroxychloroquine should not be used. But in general, for the non-cardiac patients suffering from COVID-19 is a very good compound. So this is about the earlier patients for the randomized study where only 2 patients were studied and they found that this patient also had a good 62 patients studied in Wuhan by hydroxychloroquine, and they found that the mean age of all patients, and the result was that the body, overall the recovery was faster in these patients also in Wuhan. This was actually 62 patients. Despite a small number of cases, the potential of SCQ in the treatment of COVID-19 has been partially confirmed. Considering that there is no better option at present, it is promising practice to apply hydroxychloroquine to COVID-19 under reasonable management. However, large stable. This was before the French study. So even they said that this is a useful treatment, and the French study has confirmed. So not going details, it is only authorized, it's already authorized by Indian Council of Medical Research, and therefore there should not be any controversy by the today newspaper. This is what I want to say. Though the warning is QT interval prolongation, which is doctors to know. There is another important compound which I want to highlight is the role of ivermectin. What is ivermectin? Ivermectin is a compound which is actually an anti-parasite drug. It's a FDA-approved broad-spectrum anti-parasite agent. To test the antiviral activity of ivermectin towards SARS-CoV, supernatant cell pellets were harvested at a Duthru and analyzed by RT-PCR for replication. This is an in vitro study. What is in vitro study? In vitro means it is a study which is done in the harvesting with the virus in the laboratory, not in the animals, not in the human beings. It has shown a very promising. At 24 hours, the supernatant indicative release viral 93% reduction in viral RNA. This is the only antiviral medicine which is curing and finishing off the virus from in vitro study. So, but by 48 hours, there was a 500-fold reduction in viral RNA in the ivermectin treated compared to control samples, indicating that ivermectin treatment resulted in effective loss of essentially all viral material by 48 hours. So this is a very positive thing. The effect is likely through inhibiting IMPA mediated nuclear import of viral proteins, and the results are very positive, but we need a human trial as of now. If this is an in vitro study, trial needs to be conducted in humans. The result from this in vitro study should not guide the clinical practice. So I would like to tell you that there are a lot of promising compounds, and another promising compound which my father yesterday has proposed is another anti-parasite which is yet to be approved for the clinical practice. So coming on to the second part of my talk, I think we have to finish in 10 minutes. I have to delete something which is not. How to use mask. In general, this is a very important question, although now the media has given so much of knowledge that everybody is a teacher here. And in fact, so I want to show you this is N95 mask actually. This is to be used only by healthcare workers. In general, I would like to tell you very important historical part. Now, historical means within 3 weeks. On March 26 and on March 29 and on March 17, I was on television on various channels when this was coming to India, not in that bad way as today. And I proposed that this virus can be airborne, meaning thereby possibility, because at that time there was only an indication of mask wearing inside the hospitals and only by the healthcare workers. I proposed at that time March 18, which is I have got the recording on the TV, and then March 26 and then March 29. I said everybody, this was my idea. I felt that everybody who's going out of house, even the lockdown was started on 24th March. Despite the lockdown, there are people who are going out for essentials, that they are going to buy vegetables, they are going to go to Mother Dairy, they are going for the hospitals or hospital. So whenever they are on the road, they should wear the mask, and the poor people cannot use the mask, and therefore they can use the rumal or hanky. I use the word rumaling. And also angocha. I said people can use angocha. Everybody, poor people have got angocha or gamcha in Bihar. At that time, people did not agree with me. There were other panelists. They said, don't create panic. There was everybody remembers the Anand Vihar terminal where people started migrating to their homes, the daily care workers. You remember that time, that was around 26th of March. I was on some television channel. I said that the police tell everybody to use hanky or angocha. And actually, I'm very happy that later on, even Honorable Prime Minister said, and this became a guideline from Indian Council of Medical Research, that everybody who's going out should use either the mask or hanky or rumal or angocha or gamcha. So I was very happy that my hypothesis at that time, which was laughed away by many of the other panelists, that this is not possible and this is not useful. I told that WHO later on said that this virus can be airborne. As of now, at that time, there was only a thought process that people who have got sneezing, that means the social distancing of, now I would call it physical distancing, because social media is different. Social or physical distancing was used only for 1 meter. But at that time, I said it's better to use 2 meters, because at that time WHO also felt, World Health Organization, that the virus is only transmitted through the sneezing or cough. I felt that these are, and that time it was very clearly known that the hard surface, the virus stays there for some time, about 24 hours or 48 hours. So cleaning of hard surface is very important. But nobody thought that this virus can be airborne. That means the virus can stay in the air for some time. I'm giving this important point because that time it was not sure that it can be airborne. I hypothesized in March 26 that this can be airborne. People laughed at me. But now it is very clear that this virus can be airborne. Therefore, it's very essential, now mandatory, that everybody who's going out should be wearing either hanky or mask or angocha or gamcha. This was very important, which I hypothesized and people laughed at me, is now a rule by the government. So I'm going on to the contact tracing. This is very important. I would like to tell everybody. I don't know whether you have received the messages. The Arogya Setu app, which has been released by Arogya Setu, is the Ministry of Health and Family Welfare. which has released an app which can be downloaded on all the people mobile phone. How it works? You see, there are two ways of containing this disease. One is social distancing, another is physical distancing. Of course, physical distancing is better word than the social distancing. And the third is using the mask and preventing yourself when you are locked down. The whole world is locked down. The whole world is locked down, you know, everybody, except for Stockholm. The Sweden has never done a lockdown as of today, and they want to develop a herd immunity. This is something different subject to talk about. So, Arogya Setu app means that the app which will be downloaded on all the Android phones, and they will keep a track on the people, all other people who have, suppose one person becomes in contact and he says, okay, I have come in contact and this is known. Then all the other mobiles which have been in contact with that particular person will be given some sort of warning that you have been in contact, therefore you should quarantine. So this way you can trace the contacts. That means the person who is infected, all the other mobile phones or the other persons who have this app will be given a small notice or notification that you are also have contacted that particular person 1 week back. And therefore you should keep yourself and whomsoever contacted, they should be kept in a isolation in their home and further lockdown. So this app, this contact tracing app is going to reduce the burden of social distancing, and this is going to help people, and therefore anybody can actually download this. You must be getting the messages or the emails that this app should be downloaded to all the people mobile phone, and this is going to help. There are a lot of European studies coming up. Europeans are faster than Indians and Chinese. In fact, they have done a study. I told you that a study which was done in ivermectin, and then hydroxychloroquine, and there's a recovery trial which they are doing with a lot of viruses. I'm not going to details, but I want to tell you that this is. What is plasma therapy? Everybody is reading plasma therapy in the news. What is actually plasma therapy for the general public? This is an antibody therapy. What happens is whenever the virus infects a person, I told you in the beginning that there are IgM and IgG antibodies which are produced as a part of immune response by that particular body. And this is the body immunity to develop those antibodies to kill the virus. That means the body itself produces the antibody to kill the virus. The people who have recovered, the COVID-19 infected patients who have recovered, their blood is harvested, the plasma is taken out, then the rest of the blood is transfused back to the person. That plasma, which is rich in antibody against COVID-19, that is infused into the patient who is suffering. But this, as of now, this is indicated only in a very high risk patients. Plasma or antibody therapy is known for years together for various kind of virus disease, including Guillain-Barré syndrome, which is a neurological disease which paralyzes the whole body down below and which is a reversible otherwise. This is already known. But for COVID-19, it is a new thing. And it's known that we have done 2-3 patient trial in Delhi also, and the patient has recovered. This is a very good system where we can reduce the death. It is not going to reduce the virus burden in general. For that, social distancing, mask and everything. Hydroxychloroquine as prevention. This is a specific line of treatment to reduce the mortality. As you know that so many people have died and people are dying every day. In fact, in Italy, you must be knowing it. I don't know if they know it or not. The ICU beds were reduced. There was hardly any ventilator left out because that happened so fast. Same is happening. Now Mr. Donald Trump is saying that they have got enough number of ventilators. In fact, India is now ready better than other places because we have more ICU beds available and also ventilators available if required. We are in surplus. That's a very good news. Our Honorable Prime Minister, Mr. Narendra Modi ji, and our Health Ministry and other part of India, they are more proactive and they are learning from the disease came a little later in our country. What is ventilator? Let me tell you, this is very important part for general public. This is not for the doctors. Ventilator treatment has been sometimes abused. Let me tell you, in general public, उनको वेंटिलेटर लगा दिया, जबरदस्ती लगा दिया, वेंटिलेटर पर रखे रहे. They don't understand the importance of ventilator. That's why I'm telling you and giving you another 3 minutes to understand. Ventilator is a part-time treatment. For those patients who are very sick and they're not able to breathe well. It is actually a life-saving treatment. I don't want to name the actor, the film, but there was a huge news that ventilator अस्पताल वाले जबरदस्ती लगा देते हैं और पैसा बनाने के लिए. This is something very distressing news, and we used to think how it is possible. It's impossible. Ventilator is a life-saving machine. There are two types of ventilation. One is invasive ventilator, another is non-invasive ventilator. Invasive means there is a tube which goes inside into the windpipe, and non-invasive ventilator is only a pressurized on the chest, on the mask, which is pressure. When the patient lung is diseased to that extent because of severe pneumonia that the transmission from the oxygen to the blood is hampered to that extent that this patient will not survive, his pH will become acidic, and the patient slowly goes down, he becomes hypotension, he will die. Then at that time, if you put a ventilator for the part time till the lungs itself they come back to its own normal, the ventilator will help to give good oxygen, make the pH normal, and which is alkaline 7.3 to 7.5, and increase the oxygen inside the body to that extent the patient can survive and he does not go into hypotension and death. Ventilator is required in all serious patients, all serious sick patients who go into the cytokine storm I told you in the beginning, where you have such a serious patient that the acute respiratory distress syndrome, the whole lung becomes opaque. There's hardly any place where the oxygen transfusion can take place, and the body goes down to that extent that his oxygen level saturation, which is normal 99 to 100, comes down to 80 or 70. The PO2, which is measured by acid blood gas analysis, arterial blood gas analysis, the PO2 is reduced to 60, 40 or 30. These patients are destined to die. The ventilator became less, and there was scarcity of ventilator in Italy and earlier also in USA, and therefore they could not save the patient. It's a life-saving treatment, and don't having misconception. People give ventilator unnecessarily लगाया जाता है. It's a life-saving. जब ventilator नहीं होते थे, I remember the time when I was doing MD, there were hardly any ventilator, 93, 94, 95, 96. And in fact, nebulization I saw the first time in 98 when I was working in France. So these things are actually our treatment modality to reduce the mortality. So don't mishap. What is virus disease? I've told you. Healthcare workers, I told you, lot of doctors have died. You will be surprised to know. Italian, my friends, known to me very well, few have succumbed. Cardiologists have succumbed because they are working in COVID-19. So healthcare workers are getting infected day by day. There's a specific PPE, protection equipments, personal protection equipments available now. So we are all learning. This is a new disease where you don't require. In swine flu, which happened, but that was also a pandemic, swine flu. But never ever such high infectivity was there. So we have to take care of our healthcare workers. And yesterday, we are very happy that those people who are treating the COVID-19, the ordinance passed. Mr. Javadekar was announcing yesterday, the government of India has passed an ordinance for the protection of these healthcare workers. I hope that this ordinance should be for all the doctors, not only for doctors for COVID-19. This ordinance should be coming for all the healthcare workers, and it should continue in the future. I was speaking to Mr. Javadekar day before yesterday on telephone. He was very nice in asking me how it can prevent his own maid servants and coming. And there was general questionnaire. And next day he announced this thing. Day before yesterday evening, I had a long chat with Honorable Mr. Prakash Javadekar Saab. COVID and heart. I think I have been also already 5 p.m. I will give you some slides which will tell about the cardiological part, and I will skip something because this is a very long lecture. So I will case fatality. This is an important slide. So this is JAMA published on February 24, 2020. Case fatality rate in laboratory confirmed COVID-19 patients, and they have seen that the patients at that time there was no mortality in patients who were less than 9 years. In 72 to 79%, 88% mortality is a very high mortality. You know, the bypass surgery, when we perform in a high-risk patient, the mortality, when we tell the patient the risk is only 1%. 8% mortality is very high. Those people who are more than 80 years, they have 15% people will die. If you contract infection in your elderly mother or father, the chances of that they will die is 15%. This is despite the treatment, not at home. Despite the ventilator, despite the hydroxychloroquine, despite antiviral, plasma therapy was not introduced at this time. Now plasma therapy will reduce this mortality if it can be used very well. When those patients with cardiovascular disease, established CVD, angina, heart attack, angioplasty, bypass surgery, they have in general, irrespective of age, they have a 10% mortality. This is where we are afraid. The patients who are cardiovascular disease established, that means they have a chronic stable angina or unstable angina or previous bypass surgery or previous angioplasty, they have a risk of 10% death if they contract infection. Diabetes patients, very important. India is a diabetes world capital. Why I'm saying so? Because the diabetes in India is about 10 to 15, 20%. Various studies have shown. 30% of heart patients have diabetes. Diabetes is mostly remaining uncontrolled. I'm talking of villages, where I'm talking of the places we are not having. HbA1c, which is a marker for 3 months of diabetes, is very important. Anybody who has diabetes, even if it is controlled, they have a mortality of 7%. That means the chronic respiratory disease is having less. You see, this virus is affecting the lung and more lung than the heart. But despite that, the patient who have got a lung disease already is having only 6% mortality, while the patient who has a heart disease is having 10% mortality. Hypertension is not that big problem, 6%. Those patients who have cancer, only 5%. So heart patient and the patient who are more than 80 years have to worry. So this is an important part of my topic, and I want to finalize this talk because we have to take a lot of question and answers also. In the current study, patients with underlying cardiovascular disease but with normal troponin levels during the course of disease experience a more favorable prognosis. But this is one way you can also differentiate that those patients who have a low troponin level, those patients who have a high troponin level, you can find out that these patients are going to survive or no. So this is what it is. Let me talk about the final part of my presentation, which will be on ACE inhibitors. Yes, this is important.
Dr. Gupta,
yeah.
We can just sum up in 2 minutes so that.
Yeah. This is the last slide. I told you it's the last slide. Almost, because this is important. You must be television, and everybody is announcing that high blood pressure medicines, ACE inhibitors, should be stopped in all the patients. Hypertension and COVID. A debate started. Article published in Lancet that the most frequent comorbidity report on stage is patient with COVID-19 often treated with ACE inhibitors. ACE inhibitors like telmisartan, olmesartan, cardio inhibitor, ACE inhibitors oblique ARB. So, but the study have shown that the patients who are being treated by this medicine need not to change their medicines. Earlier it was thought that they should come back to calcium channel blocker and they should talk to their doctors. But thus ACE inhibitor ARB could diminish the potential development of either ARDS, myocarditis or acute kidney which can occur in COVID-19 patients. So let me see what is the last slide. So I think I go back to the slide which I presented, and this is my final slide, and the first and the final slide, that we have to be careful, we have to take care. It is something which it's not like that, it's not curable. The vaccine will come soon. Still there are a lot of vaccine trials. Animal trials have completed, but there are no still human trial which are completed. It will take 6 months. Lockdown period will go to increase. This is my feeling. The lockdown is not going to finish on May 3, and there have been warning by WHO and UK scientists also that don't try to finish off the lockdown just because of economy. Life is more precious. Thank you very much. I feel that the lockdown will go on further, but it's all the government to decide. My personal view will be that to reduce and containing the virus, we still need a lockdown because to have physical and social distancing. Thank you very much. Then we can take a few questions.
Thank you so much, Dr. Gupta. Now, before we start the question answer, may I ask Dr. Rajesh Sharma to join this panel and then say a few words. Dr. Rajesh Sharma is here. Sir?
Yeah, just unmuting my mic. Yeah, thank you, Vaki. Dr. Gupta, it was really very informative, and particularly a person like me who had gone under the angioplasty about 5 years back.
Okay.
I think it's very important. But somehow in India, the trend was slightly different. When the government is saying that there are more younger people who are getting affected by this disease.
You see, when we had a data here, it was clearly shown. You see, Italy data showed that the people have died. They actually are more than 70 years age. Before it was, in fact, there was a study which was showing from China that less than 5 years or less than 10 years are immune to develop this disease. When we had a disease here, not only the elderly but younger people were also having disease, and therefore this disease is not that only for the elderly, it is also affecting the people of 40 years, 30 years, 25 years, 70 years, 60 years, 50 years. It's all over. So that notion that is only going to affect and affect only the elderly is not correct no longer. It is because we are all day learning, every day there is something different. As I told you, the US has said that this hydroxychloroquine is not going to work. I don't agree with that. So nobody is immune to this disease, and therefore we have to be careful.
That's right. So actually, thank you very much. In fact, your talk can be understood very easily even by the scientists and as well as non-scientists also. Very, very well explained through your slides and through your talks. Thank you very much.
Thank you, sir. Thank you, sir. Thank you, sir. And Dr. Hamstra is also here. Dr. Hamstra, can you also like to say a few words about?
I think I'll let me stop sharing the screen. Okay, so yes, and yes, we can go ahead with the question.
Okay, Chandri, can you read out the questions?
Yes, ma'am. There is a question about the advice on the non-systematic carriers. Do they run the risk of getting the disease at the some later stage? What should be the SOP for them in the interim? This is the question from Ravindra.
Actually, I could not understand the question. Can you repeat the question, please?
Sir, he is asking about the non-systematic carriers.
Asymptomatic carrier, very important question. Yes. Non-symptomatic is known as asymptomatic. You see, when the virus affects the body, it takes about 5 to 7 days for the symptom to occur. I was having a question from Bombay, from one of the celebrity. He said, I am locked down. I went out of my house only 1 month back. This was a very specific question. I'll answer that. And do you think I will have infection? I said no, because now you have crossed the 3 weeks where the virus comes over and goes. So asymptomatic carrier was not taken as a very serious thing. Again, I want to repeat, it's a very important thing. I was on one of the channel which is the Republic, and I told at that time, that was early days of 18 March, I said asymptomatic patients you have to take care. They said there is no study at that time that asymptomatic patients can also infect others. So asymptomatic carrier is 100% confirmed now. That's why there is a possibility of second wave also coming up. What do you mean by asymptomatic carrier? You mean that the patient does not have fever. For example, anybody who's in your house or somebody else outside in the hospital, patient can still have the virus. And if he coughs without even coughing, because I told you that it can be airborne, if he is talking loud, then also the virus will come out and it will infect other person. So in fact, asymptomatic carrier is a reality now. It's a reality. That was my submission hypothesis again. That's why I said the asymptomatic people are running here and there. Anybody, that time what happened in the Anand Vihar terminal, I said anybody who is not infected can be infected actually. So that time people did not agree with me. So I told you, now this is a reality. One has to be very, very careful. That's why mask or hanky or anything on your mouth always when you are outside your house. And one more thing I would like to tell you. There are a lot of people who are coming to your house to work. You cannot avoid. A lot of people are coming to your house to work. To let them wear the mask. You may not wear the mask in your house. But those people who are working inside your house and going out, if this is possible, you can let them stay in your house. It's not possible for everybody. This was the Honorable Minister was asking me.
We are doing our work ourselves. So there is another question, very interesting one. Is there any correlation between the BP medication and the severity of COVID-19?
वो voice clear नहीं है.
This is what I touched upon and I want to understand. This is a question which was there. Because a lot of media have shown that there are specific group of anti-hypertensive medicines, which is actually ACE inhibitor, ARB. Very common medicine. These are very common medicines actually. Everybody who is hypertensive is taking one of those medicines. Initially, it was thought that the virus, which is infecting inside, is also working through the same system of ACE inhibition. And therefore, they will need to change the medicine from those medicines to calcium channel blocker, because there are various types of anti-hypertensive medicines. But the European Society of Guidelines of Cardiology has shown the guidelines that those people who are not infected, they need not to change it, and therefore the patient should not change the medicine, and therefore the patient who is taking anti-hypertensive medicine whatsoever need not to change any medicine and change it to calcium blockers unless they get infected. But the infectivity will not be dependent upon what type of medicines he is taking.
I see one more question, but I'm not able to say it.
Which one, ma'am?
There was one from the
There is one more question which is appearing. That is there any risk of this transmission of this virus from mother through placenta to his child?
I wanted to show that slide. It's very important. Can I share the screen again? Please, it's a very important question. Share the screen again. So let me go back to my presentation. What about infants born to COVID mothers? There was a test antibody in infants born to mothers with COVID-19 pneumonia. There was a study which has been done, and this was published in March 26. And they have a methodology retrospective analysis of the data from 6 pregnant women from COVID-19 and admitted to Wuhan Hospital on February 16 to February March. Method and neonatal serum sample were used to target this. The results. All 6 mothers had mild clinical infections, manifestation of COVID-19. All underwent cesarean delivery in the third trimester. The infants were isolated from the mother immediately after delivery. Ampere score of infect was okay. SARS-CoV-2 infection. All 6 mothers had negative SARS-CoV-2 results. None of the infants presented any symptom as of March 28. So this was all 6 infants had antibodies in the serum, but they did not have any symptom. So the antibodies are passing from 3 infants with higher than normal IgG levels, and inflammatory cytokines increase in all infants. All mothers except 2 have had elevated IgG antibody in the serum. All mothers except 1 had elevated IgG. Discussion among 6 mothers, they confirmed COVID-19 SARS was not detected in the serum or throat swab by RT-PCR any of the newborn. The newborn did not have a major infection. However, virus-specific antibodies were detected in the neonatal blood serum. The IgG concentration was elevated in 5 infants. These findings are important for understanding the serological characteristics. So, to summarize, this is the more of it. The infants who are born to infected mother will not be infected, although they will have antibodies. That means they will behave like the people who have been infected, now they are not infected. That means they will not be having any serious issues that they will go into pneumonia. Very important question, and this small study has shown, although there was an immunity, antibodies were there in the serum, but they were not found to be infected by the PCR test.
But after that, the asymptomatic patients?
No. Anybody who has got antibodies is not a carrier. Antibody does not make you carrier unless the active virus, then only the child or anybody will be carrier. Anybody, and immunity works out in all the patients. That is why the role of plasma therapy. Any patient who has recovered from COVID-19 will have his antibodies there, and therefore they will have the antibodies there, and therefore they will not be treated as, they will not be actually infecting the others. That means the children or the infant, a small child born will have no active virus.
Then one more question, I think the last question, Shanti, you can read it out.
This. There is a one query. This asthma people, they want to know about the risk and how can they overcome these risks.
Yes. I told you, as such asthma or chronic obstructive lung disease, which is very common in India after age of 60 because of pollution, because of so many other things, and smokers have got chronic obstructive lung disease. they are not prone for any special, they are not more susceptible than other population. You see, the virus will be infecting anybody, whether he has got earlier lung disease or he has got any heart disease. Anybody can be infected. But the study has shown that those patients who have heart disease, they are more likely to die because of severity, because they have low immunity as compared to lung disease. But of course, those who are having lung disease, they are more likely to have a serious infection, going to ventilator and death as compared to general population. So therefore, any patient who is got a lung disease or heart disease or diabetes, they should take extra precaution not to be infected. But anybody who has a lung disease does not mean that his infectivity is more. If he practices social distancing, if it is using the hygiene, the sanitizers, his doctor at his home, and he's not coming into contact with anybody, that means he will not get infected. Lung disease per se does not increase the infectivity, but lung disease increases. If he gets infected, he can become more serious. You understanding my point? That means suppose a person comes here, an infected person in the room. I am sitting there, a diabetic patient is sitting there, a lung disease patient is sitting there, a heart patient is sitting there. All will get, and the person who does not have anything, there are 20 people for example, all 20 will get infected, irrespective whether he has heart disease or lung disease or diabetes. But those who have lung disease or diabetes or heart disease, they are more likely to die because they have become more serious because of the low immunity levels. But the chances of infection remains the same for everybody, irrespective of age, irrespective of whether he has got comorbidities or not. But 80% patients will recover on their own because of, they do not require hospitalization also. You see, in our hospital in Apollo, we have two types of wards. One is isolation ward, where we keep the patients who are infected, but they are not serious. Then we have isolation ICU, where those patients are kept, where those who are requiring oxygen, not ventilator, just the oxygen. Initially they require oxygen only. Then those who become more serious, then they will require non-invasive ventilation. And they become, those who become very, very serious, they will require invasive ventilation. So two types of wards all over the world. Isolation because they don't want to infect others. These are isolation wards, and they are normal wards, private wards. They live like a hotel. It's a very good hospital. In our hospital, they have reduced the cost of those wards even as per the related to the people who are non-COVID. So they live like Shansha, and they, of course, they are mentally traumatized. Anybody who gets infected. When I was really listening to the Prince Charles, and the Boris Johnson, he was so high hope that I am not infected, I am going to quarantine, don't worry, I am all right. This is a very good hope, an infected person like Prime Minister of UK, you must have heard his video. So what I am to tell you, keep social distancing. Lung disease per se is not increasing the infectivity chances, it is increasing chances of going from mild to severe infection.
Thank you so much. Thank you so much, Dr. Gupta. It was such an informative presentation, and for all the people, for scientific people as well as for the layman people, that there were so many questions. There is one more question, but there is no time. We are not taking up.
So you can take it, if you have time, I have time for 3 minutes. Don't ignore any question. The question.
There is another session lined up.
Okay.
So we have to start.
They can talk to me on the phone.
Yeah, so maybe we will pass it on to you, and then the channel we will pass it on to the rest person.
So I summarize here that COVID-19 is the biggest pandemic after Spanish flu. Lot of people might not be aware that 1902 there was a Spanish flu where more than 6 crore population was infected. 6 crore population died. More than 1.5 crore, if my data is not wrong, which I heard and read, that 1.5 crore population of India died. It was a huge mess. Even Mahatma Gandhi, our father of the nation, was infected, but he was quarantined and he survived. So, other than that, swine flu, AIDS, HIV, many other infections came. After Spanish flu, this is the second most difficult pandemic which has happened. We have to be careful. We don't want second wave to come. But all the scientists are saying that there was an article that 30% patients who have recovered, they do not have enough immunity. We want herd immunity, herd H-E-R-D, herd immunity. That means all the patients who get mild infection, they should pass on and they get infected immunity. You see, all the virus infection can get the immunity. Khansi, जुकाम, बुखार was a normal thing. सबको होता है, हर साल होता है, ठीक हो जाते हैं. Antibiotic की जरूरत भी नहीं पड़ती because they have herd immunity. But as of now, this COVID-19 does not have herd immunity all over the world. So those patients who will have, if second wave comes, it will be equally or more dangerous because still, but it may be less dangerous because now by that time we'll have more medicines. We have to be careful, social distancing, hygiene, continue the same thing, lockdown, follow the orders from the government, follow the guidelines, not the orders, and mask all the time, or rumal all the time, or angocha or gamcha. Thank you very much.
Thank you so much. Thank you so much. Thank you so much. So on behalf of all my colleagues, colleagues, Dr. Dalli is there, Dr. Hansra is there, Dr. Kuldeep Singh, Dr. Rajesh Sharma, and on behalf of our Honorable Founder President and Vice Chancellor Madam and Chancellor Sir, I would like to thank you for this giving this such a wonderful lecture and such an informative lecture. So I hope that people will be benefited by this, and this is being recorded. So those who have missed out can again see this lecture. So thank you so much. And now Charlie, would you like to say something to Dr. Gupta?
Thank you so much, Dr. Gupta, for giving your precious time and sharing your view, giving us, solving us our inquiries. There are many more questions which I would like to ask you personally once it is over. So we would like to be in touch with you, sir. And I will especially thank Mrs. Dr. Sunila Tanishwar. I can see her here. Ma'am is from the head pharmacy department at Lucknow campus. And so many faculty from biotechnology, Dr. Prachi, Dr. Rashna Chaturvedi, and Dr. Gurjeet is here. So I think they will interact you after this session. Thank you so much, sir. Thank you, ma'am.
Namaste.
Thank you. Thank you so much, sir.
Thank you. Disconnect.